Most people never think about their thyroid, not even once. It just sits there at the front of your neck, a small butterfly-shaped gland quietly keeping your body running. But when cancer shows up in the thyroid, it is normal to be scared. Here is what we want you to hear first. Thyroid cancer is one of the most treatable cancers in the world. The vast majority of people diagnosed with it go on to live full, healthy lives. In this video, we will walk you through exactly what thyroid cancer is, who is at risk, how doctors find it, and what treatment looks like. So if you or someone you love is facing this diagnosis, you feel informed and ready. I'm your host from HealthSphere MD. Let us begin. Before we talk about thyroid cancer, let us understand the organ itself. The thyroid is a butterfly-shaped gland at the base of your neck, just below your Adam's apple. It makes two important hormones, thyroxine, T4, and triiodothyronine, T3. These hormones control nearly every metabolic process in your body. Your heart rate, your body temperature, your weight, your mood, your energy levels. Your brain controls the thyroid. The pituitary gland in your brain releases something called thyroid-stimulating hormone, TSH for short, to tell the thyroid how much hormone to make. When cancer develops in the thyroid, it usually starts in the follicular cells, the cells that make thyroid hormones. Less commonly, it starts in the parafollicular C cells, which make a hormone called calcitonin. Knowing which cells are affected helps doctors choose the best treatment. Not all thyroid cancers are the same. There are 4 main types, and each one behaves differently. Type 1. Papillary thyroid cancer. This is the most common by far. It makes up about 80 to 85 out of every 100 thyroid cancer cases. It grows slowly. It responds very well to treatment, and the long-term survival rate is excellent, over 98% at 5 years when caught early. Even when it spreads to nearby lymph nodes, it is still highly treatable. Type 2. Follicular thyroid cancer. This makes up about 10 to 15% of cases. It is a little more aggressive than papillary cancer, but still very treatable, especially if caught before it spreads to distant organs. Type 3. Medullary thyroid cancer, MTC. This type starts in the C cells and makes up about 3 to 4% of cases. Here's something important. About 25% of medullary thyroid cancers run in families. They are linked to a genetic mutation called RET, a major consensus statement from the American Thyroid Association. Set guidelines saying that people with RET mutations should have their thyroid removed early, sometimes even in childhood before cancer can develop. So if someone in your family has MTC, you should be offered genetic testing. Type 4. Anaplastic thyroid cancer. This is the rarest type, less than 2% of cases. But it is also the most aggressive. Because it is so rare, specialist centers have developed targeted therapies that are improving outcomes, and clinical trials are ongoing. The good news is that the vast majority of thyroid cancer cases are papillary or follicular. Both have outstanding survival rates. So who is most likely to get thyroid cancer? Let us look at the main risk factors. Gender and age matter. Thyroid cancer is about 3 times more common in women than in men. It most often happens to women in their 40s and 50s, though it can affect people of any age, including younger adults and teenagers. Radiation exposure. It is one of the most well-established risk factors. People who had radiation therapy to the head or neck as children, which used to be given for things like acne or enlarged tonsils, have a higher risk. Radiation from nuclear disasters like the Chernobyl accident also increased thyroid cancer rates in the affected populations. Family history and genetics. They matter a lot for medullary thyroid cancer. If a parent or sibling has been diagnosed with MTC, you should talk to your doctor about genetic counseling and testing for the RET mutation. Iodine intake. It may also play a role. Low iodine diets have been linked to certain thyroid conditions, though the connection with cancer is complex and still being studied. In most developed countries, iodine is added to table salt, so this is not a big concern. Thyroid conditions like goiter and enlarged thyroid and some forms of thyroiditis may slightly increase risk. But most people with these conditions never get cancer. Here is something important to remember. Having a risk factor does not mean you will get thyroid cancer, and many people diagnosed with thyroid cancer have no known risk factors at all. Doctors sometimes call thyroid cancer a silent cancer. Why? Because in its early stages, it usually causes no symptoms at all. In fact, many thyroid cancers are found by accident, spotted during an ultrasound or scan done for some other reason. That said, there are signs you should know about. The most common early sign is a lump or swelling in your neck. You might notice it yourself, or a doctor might feel it during a routine checkup. Not all neck lumps are cancerous. Most are benign, but any new or growing lump in your neck should be checked. Other symptoms can include a hoarse voice that does not go away. This can happen if a tumor presses on the nerve that controls your vocal cords. Trouble swallowing, or feeling like something is stuck in your throat. In rare cases, trouble breathing if a large tumor presses on your windpipe. Swollen lymph nodes in your neck. This can sometimes mean the cancer has spread locally. Please remember, these symptoms are more often caused by benign conditions than by cancer. But if any of them last more than 2 to 3 weeks, please see your doctor. Early detection makes a real difference. Patients come to me after Googling a neck lump. They have already convinced themselves of the worst. I understand that completely, but here's what I tell them. Of all the cancers I see in my clinic, thyroid cancer is one of the few where I can look a patient in the eye and say, genuinely with evidence behind me, that most of the time we are going to deal with this, and you're going to be fine. Here is something I find fascinating in practice. Thyroid cancer is very often found by accident. A patient comes in for a heart ultrasound or a neck CT for a sports injury, and we find a nodule. No symptoms, no lump they had noticed. This is one reason thyroid cancer diagnoses have gone up in recent decades. Not necessarily because the disease is more common, but because we are scanning necks more often and finding things earlier. Now, I want to speak directly to patients who have been told they have a thyroid nodule and are waiting for their biopsy result. The waiting is hard, I know that, but here's what you should know. The vast majority of thyroid nodules are benign. Depending on the ultrasound features, somewhere between 80 and 95% of biopsied nodules come back as non-cancerous. The biopsy is there to give you certainty, not to confirm a fear. And for those whose biopsy does come back as cancer, please do not read survival statistics for thyroid cancer as one single category. Anaplastic thyroid cancer and papillary thyroid cancer are completely different diseases with completely different outlooks. If you have been diagnosed with papillary or follicular thyroid cancer, which together make up about 95% of all cases, you're in a very different situation from the scary numbers, sometimes quoted online. Ask your team specifically about your type, your stage, and your plan. Those are the numbers that matter for you. If your doctor suspects thyroid cancer, you will be sent for a series of tests. The diagnostic journey is usually straightforward and well organized. The first step is typically an ultrasound scan of your neck. This uses sound waves to create a detailed picture of your thyroid and any nodules or lumps inside it. The ultrasound helps doctors assess the size, shape, and features of a nodule to see if it looks suspicious. If a nodule looks concerning, the next step is usually a fine needle aspiration biopsy, F&A for short. This is a minor procedure done with local anesthetic. A very thin needle is used to take a small sample of cells from the nodule. Then a pathologist looks at those cells under a microscope. Most patients find it no more uncomfortable than a blood test. You will also have blood tests. Doctors check your TSH levels to see how your thyroid is functioning. If medullary thyroid cancer is suspected, they will also measure your calcitonin levels. They may check for thyroid antibodies too. In some cases, especially for more advanced disease, you might have a CT scan, MRI, or a nuclear medicine scan like a radioactive iodine scan. These help determine whether the cancer has spread beyond the thyroid. If you have been told you need a biopsy, try not to worry. The procedure is routine and the information it gives is essential for planning the right treatment. The good news about thyroid cancer treatment is that the outcomes are genuinely excellent for most patients. Treatment is highly effective, and the majority of people treated for thyroid cancer are cured. Surgery is the most common first step. For most thyroid cancers, the surgeon will do a thyroidectomy, removal of all or part of the thyroid gland. A total thyroidectomy removes the whole gland. A partial thyroidectomy, called a hemithyroidectomy, removes only the affected side. If cancer has spread to nearby lymph nodes, those may be removed at the same time. Modern surgical techniques make thyroid surgery safe and well tolerated. After a total thyroidectomy, you will need to take thyroid hormone replacement for the rest of your life, a daily pill called levothyroxine. This replaces the hormone your thyroid would normally make. Most people adjust to this medication very well. For papillary and follicular cancers, surgery is often followed by radioactive iodine therapy, also called RAI, or Iodine 131. Here's why this works. Your thyroid is the only tissue in your body that absorbs iodine. So a dose of radioactive iodine can destroy any remaining thyroid cells, including cancer cells, after surgery. You take it as a capsule or liquid, and it is generally well tolerated. The role of RAI has been refined over recent years. The ESTIMABLE 2 trial showed that in low-risk thyroid cancer, Low-dose RAI works just as well as higher doses. This means doctors can reduce treatment burden without hurting outcomes for most patients. External beam radiotherapy is used less often. It may be recommended for cancers that do not respond to radioactive iodine or in specific situations. For medullary and anaplastic thyroid cancers, targeted therapy has transformed outcomes. Drugs called tyrosine kinase inhibitors, including cabozantinib and vandatanib, target the specific molecular pathways that drive these cancers. Clinical trials continue to expand the toolkit available to specialists. Your treatment plan will be designed by a multidisciplinary team: surgeons, oncologists, endocrinologists, and specialist nurses, all working together, tailored specifically to you. Let us talk about prognosis. And we want to be clear, the numbers are genuinely hopeful. For papillary thyroid cancer caught at a localized stage, before it is spread beyond the thyroid, the 5-year survival rate is over 99%. Even when it has spread to nearby lymph nodes, 5-year survival remains around 98%. For follicular thyroid cancer caught early, localized 5-year survival is also over 99%. For medullary thyroid cancer, the 5-year survival rate is around 90% for localized disease. Even for anaplastic thyroid cancer, the most aggressive form, things are improving. Researchers found that some anaplastic cancers have a mutation called BRAF V600E. A study by Sabaya and colleagues tested a combination of 2 targeted drugs, dabrafenib and trametinib, in these patients. The overall response rate was 69% for a cancer that was previously almost always fatal within months. This was a remarkable change. After treatment, most thyroid cancer patients go on to live normal, full lives. Follow-up care usually involves regular blood tests to check thyroglobulin levels, a marker that can detect recurrence, and periodic ultrasound scans. Living without a thyroid is entirely manageable. Your levothyroxine dose will be adjusted until your levels are stable. Most people feel completely well once their hormone levels are right. Support is available. Thyroid cancer patient communities, specialist nurses, and endocrinology teams are there to guide you every step of the way. Before we close, here are the key things we want you to take away. 1. If you notice a lump or swelling in your neck that does not go away, please see your doctor. Do not wait. Most neck lumps are benign, but early evaluation is always the right move. 2. If you have a family history of medullary thyroid cancer, talk to your GP about genetic counseling. Finding a RET mutation early can be life-saving for you and your family. 3. If you have been diagnosed with thyroid cancer, please know that you're in a highly treatable situation. Ask to be referred to a specialist center with an experienced team. Do not be afraid to ask questions. Ask specifically about your cancer type: papillary, follicular, medullary, or anaplastic, because each has a very different outlook and treatment path. 4. Take your thyroid health seriously as part of your routine health checkups. Mention any thyroid symptoms: fatigue, unexplained weight changes, neck swelling, to your doctor. Thyroid cancer is not a death sentence. For most people, it is a very treatable, very manageable condition, and the outcomes continue to improve every year. Thank you for watching HealthSphere MD. If this video was helpful, please like, subscribe, and share it with someone who needs to hear this. We will see you in the next video.